Yeah, sure.
1 minute. Now we'll just go live and then we'll.
Just let me know once you're live. Okay.
Yes, ma'am. Yes, ma'am. Priya, are we live?
Yeah, we're live.
Okay. Hello, everyone. Welcome to the White Army Examination Demonstration Session for Surgery VIVA VOCE. We are privileged to have Dr. Chandana Sri S, Senior Resident, MMCRI Mysuru, as our mentor today. Welcome to you, ma'am.
Hi, everyone. It's indeed a privilege for me to be a part of this initiative by White Army to help you gear up for your VIVA VOCE. So shall I proceed?
Yes, ma'am. Yes, ma'am.
Okay. So today we are going to look at a few aspects that are quizzed on your VIVA VOCE as a part of your practical exam. So we have a brief session allotted to us of 1 to 1.5 hours. So we are going to ambitiously think that we can talk about surgical instruments, a few radiographs of surgical importance, and also a few surgical specimens. I am not sure if I can cover each of these in the detail required, but this will mainly be a sort of a talk that will help you know what to expect in your examinations and also give you an idea about what to study. It will also brush up whatever you have learned so far. So let us now proceed without much delay. So let us first talk about surgical instruments. We are people who work with tools, right? Surgeons are people who cannot practice their trade without tools. So it is very important for us to understand which are the tools of our trade. So the study of surgical instruments will have to include the way you sterilize or disinfect them, that is asepsis, because aseptic surgery is the norm. And you have to know the specific uses of the instruments that you are using. And in addition to the instruments, we will also have to know a little bit about the suture materials that are a part of our armamentarium, and a few other important objects that we encounter in the wards. So shall we proceed? So what is asepsis? Asepsis is, like I just told you, it is a cornerstone of sound surgical practice today. So contemporary surgery is impossible without asepsis. So asepsis has basically two components, disinfection and sterilization. So in disinfection, you eliminate all sorts of microorganisms, but you do not really emphasize on eliminating spores. Sterilization is a more complete form of asepsis with elimination of even the spores. So disinfection can be low grade or intermediate grade or high grade disinfection, and there are different methods to do this. You will not have to know in very great detail about each of these methods, but it is useful to have a broad idea about what asepsis entails, especially in the context of instruments. So most of our OT instruments, the instruments that we use in the operating room, are sterilized because asepsis is of paramount importance. And for most metallic instruments, the mode of sterilization is autoclaving. So what is autoclaving? Autoclaving is a form of sterilization which uses heat and pressure to achieve sterilization. So in standard autoclaving, we achieve temperatures as high as 121 degrees Celsius. And the pressure that is used is around 1 atmosphere, that is 15 pounds per square inch. And the contact time is about 15 to 30 minutes. If you are sterilizing some rubber objects or latex objects, you can have a shorter contact time of 15 minutes. Otherwise, you will need a longer contact time of about 30 minutes for most metallic instruments. We also have something known as a high pressure autoclaving, where you use a higher temperature of 134 degrees Celsius and you use 2 atmospheres of pressure. And you have shorter contact times because you're using higher temperature and pressure, and usually 3 minutes will suffice. The thing is, most of our metallic instruments in the operating room are sterilized by autoclaving, but there are very, very important exceptions. You cannot autoclave sharp instruments such as scissors, because autoclaving or subjecting them to wet heat will eliminate the sharpness of the tip. So the instruments will become useless very, very quickly, and this will lead to more tissue injury during the surgeries. So what is preferred instead is chemical disinfection or sterilization. So chemical sterilization is done with either 2% glutaraldehyde, which is called Sidex, for which you will have to have a contact time of close to 4 hours if you want to achieve sterilization. Also, you can use Lysol. If it is a concentrated solution of Lysol, 1 hour of contact time will suffice. If not, if it is a dilute solution, you need 24 hours. You can also use 70% alcohol or peracetic acid. The thing is, if you're going to sterilize things like scissors, you should not subject them to autoclave because of the reasons that I just mentioned. And also, it is impossible to sterilize laparoscopic instruments and fiber optic instruments by wet heat, right? So it will spoil those instruments. So even fiber optic instruments are sterilized by chemical disinfection. We also have some high-end sterilization methods like gamma irradiation and plasma sterilization. They are not routinely used in our operating rooms. So without much ado, let us actually get to understanding the parts of a surgical instrument. So these are the overarching principles that will help you understand most surgical instruments that we use in the operating room. I can obviously not cover all of them, but if you have some broad principles, you can understand pretty much any instrument that you use in the operating room. So every surgical instrument has a few basic parts. So all of them have some mechanism by which you hold the instrument. So that part is the handle. So most instruments have finger rings, as you can see in the picture here. Then they have a staff or a shank. So that is the part between the blades of the instrument and the handle of the instrument. So these shanks or shafts are of variable lengths. And then they also have a joint system. So most of the surgical instruments that we use have one of these two sort of joints. So it can either be a screw joint, which is also called a pivot joint, or a box joint. So in a screw joint, the two blades of the instrument are held together by a screw. So they pivot around a screw. So this sort of arrangement is generally seen in scissors. So we have two separate sets of blades which are held together at a hinge formed by a screw. Most other instruments that we use, they have a box joint. So a box joint is one in which one of the blades of the instrument has a box or a slot in which the other blade fits. So one within another. So this arrangement is generally seen in most other surgical instruments. And they also have another element or part which is called a ratchet or a lock. So as you can see in the second instrument close to the finger rings, there is a ratchet. That is, there is a kind of arrangement in which one blade will fit over the other. This will help lock the instrument in place. So now that we've understood the basic parts of a generic surgical instrument, let us go to specific instruments. So what you see here is known as a sponge holding forceps or a Rampley's sponge holding forceps. So here again, can you recognize a few important parts of the instruments that we just discussed? Okay, so you can see the finger ring, you can see the joint. So what kind of joint can you see here? Yeah, this is a box joint. And then what is the speciality of the tip here? So the tip has two jaws. So the jaws have a sort of teardrop shaped fenestration. Okay. And then at the tip, you can also see transverse serrations. So this will help you hold the sponge. So any surgical sponge can be held with the jaws. And once you hold the sponge or the tissue, it can be locked using the ratchet. Okay, so what are the obvious uses of the sponge holding forceps? You use it to hold sponges. So this sponge can be held either as a part of your painting and draping just before you start the surgery. You can hold a sponge that has been dipped in either spirit or povidone iodine, which helps in prepping the part for surgery. Alternatively, you can also use it to hold sponges during different steps of a surgery. You can use sponges for doing blunt dissection. You can use sponges for performing things like, mopping the free edges of the area that you're operating on. You can use it to mop the effluent coming out during a bowel anastomosis. So all these are applications where you use the sponge holding forceps to hold sponge. It can also be used to hold other tissues. So it can be used to hold the fundus of the gallbladder during a cholecystectomy. And it can also be used instead of an ovum forceps in some, some gynecological procedures. It is used to hold the lip of the cervix as well. So these are a few important uses of sponge holding forceps. Let us now move on to the next instrument, that is towel clips. Okay. So as you can see here, there are two different types of towel clips. The first one is called a backhorse towel clip, BACKHAUS, backhorse towel clip, which has the standard, finger ring with the ratchet with the box joint. So as you can see, the tip is curved and pointed. Okay, so this is used to hold towels in place. And there is one other type of towel clip known as a cross-action towel clip or a Doyen's towel clip, spelled D-O-Y-E-N, Doyen's towel clip. Okay, so this has a different joint system and a different handle. So what are the uses of towel clips? The obvious use is to hold surgical drapes or towels during surgery. It can also be used to hold a different wiring, the wiring system of your electrosurgical unit, like, your cautery probe, or even the suction tube that you use during surgery, which you attach to the suction tip. All of these can kind of mess up your surgical field by lying haphazardly. So you can neatly gather them up together and secure them with a towel clip. So alternatively, there are a few unconventional uses of towel clips as well. You can use towel clips to help you lift a flail segment of a rib fracture when you're treating a flail chest. So this is a good opportunity for you to revise what a flail chest is. So a flail chest is a kind of injury where, two or more adjacent ribs are broken at two or more different locations, resulting in a segment that moves paradoxically with respect to the rest of the thorax. Okay, so these are a few uses of towel clips. Okay, so now once you have painted and draped the surgical area, you usually proceed with an incision. So for that, what do you need? You need a scalpel, you need a knife. So when you ask your scrub nurse to hand you a knife, she assembles a surgical blade on something known as a BP handle or a Bard Parker handle. So there are a few specifications that we need to understand when we talk about surgical knives. Okay, so the Bard Parker handle comes in many different flavors. Okay, so by that I mean different sizes. So we have sizes like 3, 5, 7, and 4. Okay, so what is displayed here is size 3 and size 4. Okay, so the sizes of the BP handle 3, 5, and 7 are generally used for fixing smaller sized surgical blades like size 10, 11, 12, and 15. Okay, and the size 4 BP handle is used to fix larger blades like 20, 21, 22, 23, 24, all the way up to 25. So the blade is fixed onto the Bard Parker handle by a no-touch technique. You do not hold the blade with your hand. Instead, you hold it with an instrument such as a an artery forceps or a hemostat or a mosquito, and then secure it in place with the tip of the Bard Parker handle. Okay, so you generally use different sizes for different indications. You use a 11 number blade for something known as a stab incision, which is usually done for draining an abscess. Use a number 15 blade for making very small and delicate incisions, such as the incision that you place over the neck for a thyroidectomy. For larger incisions, you use larger blades like size 20, 24, etc. Okay, so this is about the knife. So the next important set of instruments that we have to acquaint ourselves with are hemostats. So what is a hemostat? Hemo means blood, stat means to stop. So these are clamps which help us arrest bleeding. So that is the most broad term or the most broad use of the instrument that we're talking about. So hemostats again come in different sizes and shapes. So you can either have a straight hemostat or a curved hemostat. Again, these instruments have a ratchet or a lock, and then they have a box joint, and then the blades are long, and then they are serrated, and they are traumatic. That is, if you apply it to a tissue, it will crush the tissue. So these, the blades can either be straight or curved. And then if it is large and heavy, it is termed a hemostat or an artery forceps. If it is small and delicate, it is called a mosquito forceps. So it is like tiny and dainty, like a little mosquito. So both mosquitoes and artery forceps can be either straight or curved. Okay. So this is your generic hemostat that you have to remember. This is one thing that you simply cannot afford to get wrong. Okay. So one other difference between a standard artery and a mosquito is the length of the shaft and the blade. The relative length of the shaft and blade are kind of equal in standard artery forceps or hemostats, whereas you have a shorter blade in the case of mosquito forceps. Okay. So one other important instrument in our armamentarium is something known as the right angle forceps or Lahey's right angle forceps, also known as a mixter, M-I-X-T-E-R. Okay. So it is very obvious why it is called a right angle forceps. The tip of the blades, it is kind of turned in a right angle. So this has several uses. This is again an instrument which has a ratchet and a box joint, and the tips are usually serrated and they oppose each other perfectly. So this is used mainly for dissection. So this is used to dissect various pedicles in different surgeries. So what are the pedicles that you can think of? So it is used to say dissect the pedicle in terms of in the case of a cholecystectomy, where you have to do an open cholecystectomy, where you have to dissect the Calot's triangle. It can also be used to delineate various tributaries of the great saphenous vein when it dips into the femoral vein in, you guessed it, Trendelenburg procedure, right? So these are all different uses of the right angle forceps. It is also used to delineate the superior and inferior pedicles in case of a thyroidectomy. So here you basically use it to delineate the pedicle while dissecting the tissue around it and freeing it. It will also help you pass the instrument underneath the vessel in order to secure it completely, in order to pass a ligature under the vessel and then secure it. So one other important forceps or a clamp that we use in our surgeries is the Kocher's clamp. So this will, when you usually identify this instrument properly in your VIVA VOCE, it will lead to a series of questions about Kocher. So Kocher is one very important celebrity in surgery. So his complete name is Emil Theodor Kocher. So he is a Nobel laureate in surgery, which is why you have to know everything about him. So can you think of any important contributions that Kocher made to the field of surgery? So Kocher was a Swiss physician, and he received the 1909 Nobel Prize in physiology or medicine, okay, because he did extensive work in the physiology, pathology, and surgery of the thyroid gland. Okay, so he was single-handedly responsible for reducing the mortality of thyroidectomy below 1%. You must remember that he practiced in the early 1900s. Okay, so at that time, thyroidectomy was a surgery that actually had a pretty high mortality rate. So he perfected the art of thyroidectomy and brought down the mortality of thyroid surgeries. Okay, so he did not simply stop at that. He also contributed greatly to the neurosurgery. He contributed greatly to the understanding of cholecystectomy, which is why a right subcostal incision is called a Kocher's incision. And then the maneuver to mobilize the duodenum it is called Kocherization. So Kocherization is an important step in several upper abdominal surgeries. So we have Kocher's forceps or the Kocher's clamp, which we are just talking about. Then there is something known as a Kocher's point, which is a common entry point for an intraventricular catheter to drain cerebrospinal fluid from cerebral ventricles. Okay. So when you are doing something known as an ventricular drainage, external ventricular drainage, you use something known as Kocher's point. So I told you about Kocherization or the Kocher maneuver just now. And then we have one Kocher incision for cholecystectomy. We have a Kocher incision used in thyroid surgery. Okay, so and there is even a Kocher sign, which is an eye sign in hyperthyroidism. So there is an endless list of things that are named after Kocher. So this is one surgical celebrity that you should know about. Okay, so if you correctly identify the Kocher's clamp during your VIVA VOCE, you will receive a lot of questions about Kocher. So how do you identify the Kocher's clamp in the first place? So as you can see, it is quite similar to a hemostat with one major difference. The blades are heavy and the tip has a tooth. Okay, so it has a tooth and a socket. It has a pointed tooth and a socket. So what are the uses of the Kocher's clamp? So the Kocher's clamp, because it has interlocking teeth at the tip, it is used for, better grip. So it is used to crush the base of the appendix during an open appendectomy. And it can also be used for various other procedures like gripping tough fascia. And it is used by obstetricians for performing artificial rupture of membranes. Okay, so these are a few uses of the Kocher's clamp. Next, we move on to something known as analysis forceps, which is again a very, very versatile surgical instrument. So this is again an instrument with a ratchet or a lock and a box joint. And as you can see, the tip, the blades or the tip, they end in a triangle with the base, distally, and the base of the triangle has teeth. Okay, so it has teeth with an interlocking system. So when you grip something with it, it is a traumatic grip. So this is generally used to hold tough tissues such as external oblique aponeurosis. It is used to hold fascia, and it is often used as a substitute for towel clips when you run out of them. So the Alice forceps is generally, like I just said, it is used to secure the edges of tough tissues when you're suturing them or when you want to retract them laterally. Then we have something known as Babcock forceps. So Babcock forceps are pretty similar to the Alice forceps with two major differences. One is the grasp is atraumatic because the tips of the blades are blunt. So they are smooth and blunt, and the tip is triangular, curved, and it has a triangular fenestration or a window on both sides. So this is for the tissue to bulge out when you grip it. So the Babcock forceps is used to grasp the appendix during an appendectomy. It is used for grasping the bowel or the stomach or any viscous, hollow viscous, because it is atraumatic. If you hold it with just a gentle single lock, the tissue will not be damaged. It is also used to hold the fallopian tubes during a tubectomy. Then we have something known as Lane's tissue holding forceps or gland holding forceps. So here, this is again a similar instrument with rings for the handle and the ratchet and a box joint with short, stout, curved tips with oval fenestrations and a toothed tip. So this is used to hold tissues during various surgeries. It is used to hold the breast during the mastectomy, and then it is used for holding other tissues. The fenestration that you see is for the tissue to bulge out when you are holding it. So this is one other important instrument that you should know about. Then we come to needle holders. So needle holders are a few very important points that you need to know about needle holders to distinguish them from other similar instruments are, they have a very short, blade system. If you compare the length of the shaft and the blades are relatively short and stout, and the blades are triangular and pointed with cross serrations. And most needle holders, they have a linear longitudinal slit, which will help grip the needle better. So the shaft of the needle holder can be either straight or kinked, as you can see in the picture here. So needle holders are obviously used to, grasp the surgical needles. So when you identify the needle holders properly during your VIVA VOCE, your examiner may ask you how exactly you grip the needle holder, where exactly you hold the needle. So where should the needle be held? Okay, so this is something for you to find out and remember. So do you hold the needle at the tip? No. Do you hold the needle at the fag end away from the tip? Do you hold it where it is crimped to the suture material? No. So where exactly do you hold the needle? Okay, think about it. When we talk about surgical needles, we'll discuss this in detail.
At the junction of 1/3 and 2/3.
Okay. Yeah, that's correct. So where do you hold it?
At the junction of 1/3 and 2/3 of the needle.
Very good, very good. So who answered this question? Can I know who just answered?
Anushka, ma'am. Anushka.
Okay, Anushka. Very good. So you hold it at the junction of the distal 2/3 or the proximal 2/3?
Distal, proximal 2/3 and distal 1/3.
Very good, very good. And actually, this point where you grip the needle can be adjusted when you want better leverage. If you want better leverage, you can hold it closer to the tip, relatively closer to the tip. If you want, better swing with your wrist, you can hold it away from the tip. So you basically, as Anushka rightly said, you hold it at the junction of the 2/3 and 1/3, the proximal 2/3 and the distal 1/3, and you can adjust that slightly depending on whether you want more leverage or you want better swing with the wrist. And one other important point regarding handling surgical instruments is one ring of the handle will go around the thumb. The other ring goes around the ring finger. Okay, always remember this, boys and girls, all rings go around the ring finger. I have seen a lot of novices putting the ring around the index finger or even the middle finger. If you do that, your grip of the instrument will be wrong and you will be very awkward when you handle the instrument. So you should always put the ring around the ring finger. Another good practice is to lock the instrument and palm it. That is, you hold the handle with your palm. And when you are inserting your fingers, do not insert the fingers all the way up to the base. So hold it somewhere near the middle phalanx or even the proximal interphalangeal joint. Do not slide it all the way, because when you have to transfer the instruments or change the instrument, change the grip, it becomes very awkward. So these are little things that you learn by doing or watching keenly. So let us move on to the next instrument, scissors. Right, scissors are like they are quite straightforward instruments, but there are a few things that you need to understand about scissors. Scissors aren't very, very commonplace. They are not your kitchen or garden scissors. Surgical scissors are rather different from your garden scissors. Okay, so how are your surgical scissors different? Okay, so you have different types of surgical scissors. The first one that you can see, the first two, the pink one and the gray one, which are laying horizontal, they are called McIndoe scissors. Okay, MCINDOE, McIndoe scissors. So these are very delicate scissors with a long shaft and a short tip, with short and delicate and very slender tip. So this is generally used for say cutting the external oblique aponeurosis while you're doing a hernia surgery or an appendectomy. Again, this is a good opportunity for you to pause and recollect the steps of an open appendectomy. After you have incised the skin at the McBurney's point, you deepen the incision through the campus and the scarpa's fascia, and then you once you are done dissecting the subcutaneous tissue, you encounter the what do you encounter? You encounter the external oblique aponeurosis, the glistening fibers of the external oblique aponeurosis. So once you incise the fibers along the length of the fibers, you lift both the tips, and then you have to cut the external oblique aponeurosis along the length of the fibers. And for this step, we use the McIndoe scissors. Okay. One other scissors that you you can see adjacent to it with relatively longer blades, they are called Metzenbaum scissors, spelled METZENBAUM, Metzenbaum scissors. Okay. So these scissors can again, be, as you can see, what is the main difference that you see in this instrument compared to the other instruments that we have been discussing so far? What is the joint here? Is it a box joint or a pivot joint? Anybody?
It's a screwed pivot joint, ma'am.
Yeah, it is a screwed pivot joint. As you can see from the figure here, you can see the screws as well. So, and one other important thing that you can see, especially near the handle, what is the major difference between these instruments and the other instruments we have been discussing?
No rachet, ma'am.
No rachet, exactly. You don't want a rachet when you're cutting something, right? You want your cutting movements to be smooth and you want it to glide through the tissue. You do not want something to lock. There is no, you don't hold anything with the forceps, you mean scissors, do you? Can you use the scissors to hold anything? No. So that is why we do not have a rachet and we do not have a box joint. Instead, for easier gliding movements, we have a pivot joint or a screw joint. Okay. So that covers two different types of scissors here. Can you see another kind of weird, twisted kinked scissors in the bottom of the page? So those are called Heath's suture cutting scissors. Okay, spelled HEATH. Heath's suture cutting scissors. As you can see, it is very ergonomically fashioned for you to, slide the tip of the scissors, one blade of the scissors under the suture material, and then lift up the suture material and cut it. Okay, so this is used generally for cutting the sutures, for suture removal. Okay, so Heath's suture cutting scissors, McIndoe scissors and Metzenbaum scissors are a few important scissors that you must be aware of. Okay, after we have looked at scissors, let us now move on to forceps or dissecting forceps. So we, as you can recall, we've been calling them artery forceps, we've been calling them Alice forceps and Babcock forceps, but they were all clamping forceps. Okay, so they are generally forceps that are used to clamp things, different kinds of things. Babcock forceps will help you clamp delicate tissue. Alice will help you clamp tough tissue, and artery forceps will help you clamp blood vessels to arrest, bleeding. But here, dissecting forceps are they serve a different purpose. They only help you hold stuff and they help you dissect stuff. So when you're dissecting something, you delicately hold the tissue up and then dissect underneath using another instrument. So dissecting forceps are generally instruments that you hold with your left hand if you are a right-handed person, right? So you hold the forceps with your left hand and you use your working instrument with your right hand if you are a right-handed person. Okay. So there are different types of dissecting forceps. So as you can see on the screen, there is one straight dissecting forceps known as a DeBakey forceps. And the one displayed here is a smooth DeBakey forceps. Then you have an Adson's straight forceps again. So the Adson's differs from the DeBakey forceps in the way the tip is configured. Okay, so it has a broader base and the tip tapers off. And then you have, dressing forceps. As you can see, the dressing forceps is, the tip is broader. The DeBakey has a taper, a long taper. The Adson has a steeper taper. And the dressing forceps, it has a relatively broader tip. So all of these forceps, especially the DeBakey and the Adson's forceps, they come in two variants. They can either be a smooth-tipped dissecting forceps or a toothed dissecting forceps, where you have, a tooth and a socket for the tooth at the tip of the instrument. Okay, so naturally and more obviously, the smoother variants are used to handle delicate tissue, like internal structures like bowel when you are holding it up, and the toothed variant is usually used for holding tougher tissues such as the skin. So when you're suturing the skin, you use a toothed forceps. Okay. Let us now move on to retractors. So we have different flavors of retractors, so with different fancy names. I have not, listed all of them or displayed all of them because it can get really confusing. So here are a few very important retractors that you have to be familiar with, and these are the retractors that general surgeons use day in and day out. So it is useful to know these names, because when you ask your scrub nurse for retractors, if scrub nurses generally conversant with these names. So the first one that you can see with a curved, curved blade is something that is called a Doyen's retractor. Okay, DOYEN, Doyen's retractor. So how do you remember most? And the one next to it, with the curve which looks like the limb of a question mark, that is called a Deaver's retractor. So most students that I have seen, and actually myself personally, back when I was a UG, I had issues with remembering which one was called Doyen's and which one was called Deaver's. So here is how I remember it. I think you might find it useful too. So Doyen's has a Y, right? So the Doyen's retractor looks something like a Y with its curved blade and the stalk. So that is how you can remember that. That is what the Doyen's retractor looks like. The Deaver's retractor obviously is larger with a curved broad blade. And then we have something known as a Czerny retractor. Czerny spelled CZERNY, Czerny's retractor. So it has a flat curved blade, and it also has two pointed sort of blades on the other end with a stalk connecting the two, and the stalk usually has a fenestration or a window, an oval window. Okay, so that is the Czerny retractor. And then we have something known as the Langenbeck retractor. So the Langenbeck retractor is more straightforward. It has a kind of angular, perpendicular sort of blade with a curving tip, and it has a ring and an oval fenestration at the handle. Okay, so all these retractors are, the first two are generally used to retract the the Doyen's retractor is usually used to retract the bladder downwards. The Deaver's retractor is generally used to retract either the abdominal wall or the liver away from the operating field. And the Czerny retractor is usually used to retract the skin and the other tissues away from the operating field, and the same holds for the Langenbeck retractor. Then we also have a system of self-retaining retractors that are used in various fields. We have abdominal and pelvic self-retaining retractors. Then we have Joel's self-retaining retractor for thyroid surgeries, and then we have different self-retaining retractors for mastoidectomies. So they have a lock system and elaborate grid of instruments that will help hold a system of retractors in place. I'm not going to confuse you with all of that. By all means, if you're interested, you can look them up in textbooks or online. Okay. Let us now move on to another important instrument, that is intestinal clamps. Okay, so the intestinal clamps are again, we return to the old system, right? We have a box joint and a ratchet. That is, it is an instrument with a lock. And here we have long blades which do not completely oppose. Okay, so there is, when you lock the instrument, there's actually a gap between the two blades. So, and then the blades, they may have longitudinal serrations, and the tip does not crush the tissue that you are holding. So it gently but firmly holds the tissue. So this is exactly what we want when we are holding something delicate like the bowel, right? So intestinal clamps are generally used for occluding the bowel during a resection and anastomosis. So if you answer this correctly, you will get a volley of questions about what are the indications for resection and anastomosis of the bowel. So it can be either due to gangrenous bowel, or it can be due to a very extensive perforation which cannot be repaired primarily. It can be when you are excising a tumor, or if you are going to do a diverticulectomy in case of a Meckel's diverticulum. So there are several indications for using intestinal clamps for dissection and anastomosis. So a few related instruments that you can look up at this juncture are, gastrectomy clamps. Okay, the gastric clamps are pretty similar, but they're slightly smaller in size. And then we have, a kind of outdated instrument called the Pearce gastric crushing clamp. Okay, Pearce is spelled PAYR. Okay, so this was generally used in the case of partial gastrectomies to, applied on the side, which will be resected as the specimen. Most surgeons do not use it. Then we also have a system of clamps called the gastrojejunostomy clamps, where you have two kind of interdependent clamp systems where one side is applied to the stomach, the other side is applied to the jejunum to hold them both in place while you are fashioning a gastrojejunostomy. So these, you can look them up in various standard textbooks, or you can look them up online. Most VIVAs usually do not feature these complex instruments. Okay. Let us now move on to something quite straightforward. Again, this is a change from the pattern that we have been seeing in the past few slides. Can anyone tell me how this instrument is different?
Again, no
What kind of
ratchet,
joint
ma'am.
can you see?
Box joint, ma'am.
Yeah, it is a box joint. But what is one important thing that you see here? It has a box joint, but it does not have.
Ratchet.
Yeah, it does not have a ratchet. Okay, that is because you do not need to lock this. And then what do you see at the tip? So the tip tapers off, and then
Serrations.
just it becomes a little rounded, and then it has transverse serrations. So these serrations are generally used to enhance the grip of the instrument. So Lister sinus forceps is generally used for packing sinuses, right, or abscess cavities. So once you have drained an abscess and you leave behind a dead space, in order to prevent the obliteration of the dead space, or in order to prevent fresh collections, or to drain the fresh collections, you usually pack such abscess cavities. So you pack the cavity with a ribbon gauze. So in order to pack the gauze, in order to advance the gauze into the cavity, we use Lister sinus forceps. You can also use the Lister sinus forceps to break any loculations once you have drained the abscess. So if you answer this question correctly, you will be asked a question about the principle behind abscess drainage. So you will be asked about the Hilton's method of draining an abscess. Does anyone in the audience know what Hilton's method is?
Ma'am, parallel to neurovascular bundles, not
Very
perpendicular.
good. So your incision should be parallel to the direction of the neurovascular bundles. What will happen if it is perpendicular?
It will injure those nerves and
Yeah,
vessels.
have a very high likelihood of transecting the neurovascular bundle. So whenever you are doing an incision and drainage of the abscess, especially in key areas like the parotid. So when you are draining a parotid abscess, what do you watch out for?
Do not injure the facial nerve, those 5
Very
branches.
good. So what is the orientation of the facial nerve in the parotid region? It is?
Pes cavus.
Yeah, it is horizontal. So it runs from the tragus horizontally. So when you are placing an incision there, you should never place a vertical incision. At least, okay, even if you place the skin incision horizontally, when you are incising the parotid fascia, you should always make sure that your incision is horizontal. That is, it runs parallel to the direction of the facial nerve. Very good. Okay. So let us now move on to the next instrument. So what do you see here? Very weird looking instrument. It is called Desjardins cholecystectomy. What is this? It is a instrument that is used to hold gallstones. So it is called a
choledocholithotomy forceps.
Choledocholithotomy forceps or Desjardins forceps. So when do you do a choledocholithotomy? What is choledocholithotomy? Choledocus means bile duct. Okay. So you are going to incise the bile duct to deliver stones in the bile duct. So whenever there are CBD stones, when you are doing a CBD exploration, in order to deliver the stones within the length of the CBD, you use this forceps. So what are the features here?
Again, no ratchet and no serrations at the jaw, ma'am.
Yeah.
Screw joint.
Yeah, and it's a pivot joint. It is a screw joint or a pivot joint. There is no, obviously you do not want to lock the stone, right? If you lock the stone, you will end up crushing it. It will come in the way of delivering the stone. So you have, the blades, they have a slot for the stone to fit in, and you gently grasp the stones and deliver it. So also the length of the blades are quite long. The shaft and the length are long in order to maneuver the stones easily while removing them. Okay. So if you answer this correctly, you will be asked questions about choledocholithotomy. So how do you place the incision on the common bile duct? What will be the direction of your incision? And for this, you should know about the arterial supply of the bile duct. So what is the anatomy of the arterial supply. Okay, so we have something known as the 9 o'clock and 3 o'clock arteries. So how are they oriented, and how do you avoid injury to these arteries? How do you avoid devascularizing the length of the CBD? So all those questions will come, and then they can even ask you about how you ensure that you have not left behind any stones in the CBD. Okay, so read up on all these points. So these were a few important instruments that we use during open or conventional surgery. I am sure that the UG VIVA will not really ask a lot about laparoscopic instruments, but it is useful to have some degree of familiarity with these instruments. Okay, so most laparoscopic instruments are either instruments that you use at the ports, which are trocars and cannulas, or instruments which form a part of the optical system, which helps you see inside the abdominal cavity, which include the scope, camera, and the light source. Or it can be a part of the insufflation unit, which will help you deliver gas inside the peritoneal cavity to create a pneumoperitoneum. Or it can be a part of the electrosurgical unit, that is either monopolar or bipolar or advanced devices such as harmonic devices, ultrasonic devices like the harmonic scalpel, and working instruments such as the Maryland dissector, the scissors, the Babcock forceps, the graspers. Okay, we will quickly rush through this. Don't worry if you don't get most of it. But this is just for superficial familiarity with these instruments. So what are trocars? So trocars are something that will help you enter the abdominal cavity. Okay, so we usually have two standard sizes, 5 mm trocar or a 10 mm trocar. We also have 7 mm trocars, we have 12 mm trocars, but then most trocars, the larger trocars are 10 mm and the smaller ones are 5 mm. So the primary trocar through which we pass the scope is generally a 10 mm trocar, 10 mm port, but it can also be passed through smaller trocars. Okay, and then we have the optical system with the scope. The scope can either be a 0-degree scope, where the surface of the scope is it's just flat, or you can have an angled scope or a 30-degree scope, which helps you improve your field of vision. Anyway, don't worry much about all this. We have to now understand the parts of a working instrument, just like we understood the parts of a working instrument in open surgery. Okay, what you see in the top is a generic laparoscopic working instrument. Okay, here again we have a handle system. Okay, so just above the handle system, can you see a stalk jutting out? So that is usually that is a knob that we use for connecting a electrothermal device. Okay, so you usually connect the cautery wire to that knob that is jutting out, that metallic knob that is jutting out. Then can you see a triangular knob that is leading to the shaft of the instrument? So that is the knob that will help you rotate the tip of the instrument. Okay, so then the long black thing that you see is a Teflon coated sheath. Okay, so the sheath provides insulation. It provides inside the sheath you have a metallic a stem of the instrument. So that stem is it is insulated from the rest of the instrument and the abdominal cavity by means of a Teflon coated sheath. Okay, so this sheath has to be complete. There should not be any breaks in the sheath, or else it can lead to various electrothermal injuries during laparoscopic surgery, such as coupling injuries, direct and indirect coupling injuries. Again, this is something that you need to read up on. Okay, read up about the electrosurgical unit, the different types of electrosurgical devices such as monopolar, bipolar, cautery, and different other energy sources in surgery such as harmonic scalpel and advanced bipolar devices. It is certainly desirable to know about all of them. Okay, and then finally what you see is the instrument itself, or the tip of the instrument. So there are various instruments. We will look at them one by one. This is the most versatile laparoscopic instrument. It is called a Maryland dissector. Okay, so one other thing about the handles. So what you see here is a handle without a lock system. Okay, so this handle without lock system is used only for two instruments. It is used for the scissors and it is used for the Maryland dissector. So this is the Maryland dissector. It looks pretty much like the tip of a mosquito, if you want a basis for comparison. So it has serrated edges. It will help you grip instruments. It will also help you dissect through the tissue. Okay. So this is usually used for dissecting the Callot's triangle during a laparoscopic cholecystectomy. Okay. And you can also connect the handle of a Maryland dissector to the electrosurgical unit, and it will help you coagulate. Okay. Then we have the scissors. So the scissors are again an instrument that are put inside a laparoscopic handle without a lock. Okay. And then for locked instruments, we use graspers. As you can see here, we have different types of graspers: fenestrated bowel grasper, atraumatic grasper, toothed grasper. All of these are used for grasping instruments inside, grasping tissues inside the abdominal cavity. Okay. And then we have something known as a suction and irrigation cannula. So it has two different, inlets and outlets. So one is for irrigating the fluid, and the other is for sucking back the fluid. Okay, so you can alternate between the suction and the irrigation functions using a knob. Okay. Then we have something known as a crocodile or a gallbladder extractor. So it has a claw-like or a jaw-like system at the tip. So you generally pass the 10 mm port, and at the end of the surgery, it can be used to extract the gallbladder. Okay. So this is a very, very brief and non-comprehensive overview of the various laparoscopic instruments. I am only touching upon them because in case you are asked about them, you will have some general idea, and it will help you study them better. Okay. You don't have to worry about them much. Now let us move on to a very, very important topic of suture materials, right? So most people are overwhelmed with the concept of suture materials, about things like how do you choose the suture material, how do you choose the type of suture material, how do you choose the type of needle, how do you choose the size of the suture material, how exactly do you make these decisions, right? So to make this very easy for you, I will talk about different types of suture materials. So based on the origin of the suture material, the suture materials can be classified as natural and synthetic. Okay. So natural suture materials come from sources in nature. For example, we have cotton thread, right? It is one of the simplest suture materials. So cotton and silk as well. Silk comes from Bombyx mori, right? That is the silkworm. So it comes from the fibers of the cocoon of the silkworm. And then we also have catgut. So what is catgut derived from? Anybody in the audience? Do you get it from cats? Anybody?
Sheep gut mucosa, ma'am.
Yeah. So you get it from the
Sheep gut mucosa.
Yeah. So you get it from the submucosa of the gut of the sheep, right? So that is catgut. So again, that is another natural origin suture material. Then you have a few metal sutures as well. In the past, they used to use silver sutures, especially, Bassini and, those people who pioneered different types of hernia repairs. They used to use silver. So that is another naturally occurring substance. Okay. Then there are a few synthetic substances. Okay. Most contemporary suture materials that we use are synthetic substances. So one very, very versatile synthetic suture material is polyglactin. What do you guys call polyglactin? What is the brand name? Everyone thinks that is the name of the suture material. It is purple in color. Anybody in the audience?
Vicryl.
Very good, Vicryl. So please do not say Vicryl in your VIVA VOCE. Okay. Vicryl is the name, the trade name of the polyglactin suture material when it is manufactured by Ethicon. That is a daughter concern of Johnson & Johnson. Okay. So it is a very specific brand name. So you're not lobbying any brand right now. So when they show you that purple absorbable braided polyfilament suture material, what do you call it? Polyglactin. Very good. Okay. So again, so that is a synthetic suture material. Then we have nylon. Okay. Then we have polyamide. So nylon or polyamide is again a synthetic suture material. Then what is PDS? So PDS stands for polydiaxonone suture. That is another synthetic suture material. So this is how we classify suture materials based on their origin, the substance of origin. Okay. So now we have examples. So someone quickly tell me examples of natural suture materials.
Cotton, silk, and catgut.
Yeah, very good. And then synthetic suture materials.
Polyglactin, nylon, and polydiaxone suture.
Very good. So these are few broad examples of these suture materials based on the classification of natural and synthetic. Then we also classify them based on their structure. Okay. So are they monofilament or polyfilament? Okay. So monofilament is when the entire cross section of the suture material is made up of a single unit, right? So you don't have many threads, you have a single unit of thread forming the entire length of suture material. Okay. So you generally see this in nylon. Okay. So nylon, polyamide, and polypropylene, which you guys generally call Prolin. Prolin is again a brand name. So polypropylene, nylon, polyamide, and polydiaxonone suture. All of these are monofilament sutures. That is, an entire length of thread is formed by a single unit. Okay. Then we have polyfilament suture materials, where you have several threads of suture material which are braided together to form the suture. So one classic example for that is polyglactin or vicryl. Okay. One other example is what kind of suture material is silk? Is it a polyfilament or a monofilament? Anybody in the audience?
Poly.
Very good. It is a braided polyfilament suture material. So several threads of silk are braided together to form a silk suture. Okay. So it is a braided or a polyfilament suture material. Okay. So that is one other way of classifying the suture materials. So monofilament is a single thread. Polyfilament is braided threads, several braided threads to form one suture material. Okay. So this is how you classify them based on their structure. Then there is one other classification that is based on their property or their behavior inside the body. So do these suture materials, do they get absorbed inside the body after some point, or do they stay in the body as such? So based on this property, we classify suture materials as absorbable, delayed absorbable, and non-absorbable suture materials. Okay. So there are some suture materials which get absorbed after a while. So the most common example for absorbable suture material is, anybody?
Vicryl.
Vicryl. Okay, I just told you should not say vicryl. What should you say?
Polyglactin, ma'am.
Very good. Who said that?
Tejaswini, ma'am.
Oh, very good, Tejaswini. Okay, so the most common examples for absorbable suture materials are polyglactin and also catgut. Okay, so here is one more bonus point for you. What is the difference between the absorption of vicryl or polyglactin and catgut? So because catgut is of animal origin, it undergoes enzymatic breakdown. Okay. And because vicryl is synthetic, it undergoes hydrolytic breakdown. And hydrolysis is something that is generally, more predictable, whereas enzymatic breakdown is less predictable. Let me explain. Say the breakdown of something depends a lot on enzymes. Okay, so because enzymes are highly dependent on the pH and the other factors in the immediate environment, say something like an abscess or an infection it can make the absorbability of the suture material very, very unpredictable. Okay, so that is why when there is something like infection and the native tissue on which you are using the suture material does not heal quickly, it is wiser to use something with a more predictable absorption. So it is not very wise to use catgut. Say if you are doing bowel anastomosis in a very contaminated field, if you use something like catgut for suturing the bowel, because of the unpredictability of the absorbability of catgut in those situations, it can lead to leaks because the integrity of your repair can suffer. Okay. So, like I was telling you, absorbable suture materials will get absorbed either by hydrolysis or by enzymatic degradation. Okay. So, which are the other absorbable suture materials? You know, there is one more absorbable suture material known as monocryl. Okay. Monocryl is again a trade name. The polyglycopyrrone is a monofilament absorbable synthetic suture material, which again is, like I was just telling you, it is an absorbable suture material. So monocryl, polyglactin, and catgut, and even chromic catgut. Chromic catgut is where the catgut is plated by chromium. Okay, so it will enhance the durability of the suture material and also enhances the glide of the suture material through tissue. Okay, so these are all examples for absorbable suture materials. Then there is something between absorbable and non-absorbable, and that is delayed absorbable. And we have one, classic example for that. And that example is, anybody? Any guesses of a delayed absorbable suture material? I can't hear you. Louder, please. Okay, it is polydioxazine or PDS. Okay, so PDS is delayed absorbable suture material. So it does get absorbed, but it gets absorbed over a very, very, very long period of time. Okay, so it stays in tissues for long periods of times. Okay, to give you an example, or to give you a good idea, the durability of suture materials is discussed in terms of loss of tensile strength. So the tensile strength of a suture material will tell you how strong it stays and for how long. Okay, so the PDS or polydiagonal suture, it maintains its tensile strength for about 56 days. Okay, so at 2 weeks after you place it inside the body, up to 70% of the tensile strength is retained. Whereas at 4 weeks, it decreases to 50%, and at 8 weeks, it loses its tensile strength. It comes down to about 25%. But it is absorbed completely by hydrolysis by about 180 to 210 days. That is 6 to 8 months. So it takes 6 to 8 months for polydiagonal suture material to get completely absorbed. Okay. Whereas for vicryl or polyglactin suture materials, the absorbability is much more rapid. Okay, so it maintains its tensile strength for about 1 month, that is 28 to 30 days. It gets absorbed by 80 to 90 days. Okay, so this PDS stays for almost twice as long. Okay, so this is PDS is a delayed absorbable suture material. There are a few non-absorbable suture materials. And the examples for those, the classic example is polypropylene. Okay, so polypropylene is a monofilament, synthetic, non-absorbable suture material. Okay, so it is an example for non-absorbable. One other example is polyamide. Another example is nylon. So all these sutures do not get absorbed inside the body. Okay, so now quickly tell me examples for absorbable suture materials. Anybody?
Polyglactin and catgut suture.
Okay. And then for delayed absorbable?
PDS.
Very good. And for non-absorbable?
Nylon. And this one.
Polypropylene. Okay.
Polypropylene. Yes.
Okay. Now I will ask you, I will name a suture material. You have to tell me which type it is based on its origin, based on its structure, and based on its behavior. Okay. Polypropylene. Okay. I will give you an example. Polypropylene is a synthetic monofilament non-absorbable suture material. Okay. Now, does anyone want to try? Polyglactin. So go. Tell me the properties of polyglactin.
It is synthetic, absorbable, and polyfilament.
Yeah, very good. Who answered?
Tejaswini, ma'am.
Very, very good. Okay. Okay, someone else tell me about polyamide or nylon. Anybody in the audience?
Synthetic
Mm-hmm.
and absorbable.
Hey, no, nylon is non-absorbable. Okay,
Synthetic.
nylon is non-absorbable. It is non-absorbable, synthetic, and monofilament. Okay, so nylon we generally use for skin closure, for suturing the skin. Vicryl you generally use for suturing structures such as, bowel. It is used. There are 2 layers of bowel anastomosis. So in that it is used for the inner layer. Okay. So again, homework for you, figure out what are the 2 layers of the classic bowel anastomosis. Okay, described by, okay, again, find out. Then one other thing you need to know is, there is some property of suture materials known as memory. Okay, so suture materials, they come in packaging. Okay, the suture materials are folded on itself, and they are placed compactly inside a package. So once you remove the suture material out of the package, you might have noticed in some suture materials, the way in which it was packed, it will be retained by the suture material. Even if you pull it, if you try to pull it straight, release it, it will coil back again. Okay, this is something that we only in monofilament. So monofilament sutures, they have something known as memory. That is, remember how they have been placed inside the packing material. So why is this property of memory important to us? So suture materials with high memory, they will have a poor knotting property. So when you try to knot these suture materials, they will remember how they were placed, and they will try to in the package, and they will try to get back to that. So in order for the knots to be more secure, you have to put more number of throws, or put several knots one on top of the other. This is why we put several throws with proline, and put multiple knots of at least 6 knots with proline, okay, or polypropylene. Whereas braided or polyfilament sutures, they do not have memory, so they have excellent knotting property. So when you knot these suture materials, the knot is very secure. But the problem with braided suture materials is, because they are braided, they are kind of rough, and the way they glide through tissue, it is not very smooth. Okay. Whereas monofilament, because it is a single unit, when you pull it through tissue, it glides very, very smoothly. Okay. One other problem with braided suture material is the gap between the braids that can harbor secretions, and those secretions can form a nidus for infection. So when you use braided suture materials in infected areas, or contaminated areas, the risk of infection is higher. Okay, so this is a very, very broad overview of suture materials. So one other thing that you might be asked to do in your VIVA is describe the suture material. Okay, so there are so many specifications on the packaging. Okay, so you have the as you can see from the slide, you have the manufacturer. Ethicon is a manufacturer. It is a medical wing of Johnson and Johnson. Then Ethilon is the brand name of the suture material, and the actual name of this suture material is polyamide. Okay. Then what are the specifications do you see? You see something known as US gauge. So that will tell you the size of the suture material. Then can you see something that is written below PS2? There is something written there, 19 mm. Okay, so that is the length of the needle. Then below it you see something known as reverse cutting. Okay, and below that you see a inverted triangle. So that is the cross section of the needle. Okay, and then the needle type. Okay, you can see a half moon or a crescentic picture there. So that is the shape of the needle. And then below that you have the length of the suture material. So this package contains 45 centimeter of the suture material. So all of this is mentioned on the packaging itself. So that is why we need to understand a little bit more about the structure of the surgical needles. Okay, so based on how large the needle is, it can either form half of a circle, one half of a circle, or it can form 3/8 of a circle, or even 1/4 of a circle, or more than half, that is 5/8 of a circle. And rarely you can have straight needles. Straight needles are generally not used much in contemporary surgical practice. Okay, so this is based on the configuration of the needle. Then based on the tip of the needle, you can have something known as a taper tip. Okay, so the tip tapers off, so it will have a rounded body which will eventually become a pinpoint. Okay, then you have something known as a reverse cutting needle. So if the tip, if you do a cross section of the needle, you have a triangle, and the apex or the sharp part of the triangle comes on the convex side of the needle. Whereas if the tip or the sharp edge of the triangle comes towards the concave side of the needle, it is called a conventional cutting needle. Then you also have a blunt or a round bodied needle. Okay, and then you have a triangular, or a pointed needle. So all these are different configurations of needles. Generally, we use cutting and reverse cutting needles when we are suturing tough tissues, especially skin. Okay, so when you are suturing skin, you need something that will cut through the tissue when you take the bite. But you do not want this when you're suturing delicate tissue like bowel. So what happens, or when you're suturing blood vessels? So what do you want when you are anastomosing bowel or blood vessels? You want a leak-proof stitching. So for it to be leak-proof, when you take a bite with the needle, if the cross-section of the bite is triangular, and your suture material will obviously have a circular cross-section, there will be a gap between the hole made by the needle and the suture that passes through it. So that can leak. And whenever you use a cutting needle, it can injure the tissue and cause the tissue to get torn or dissected, which is why we avoid cutting or reverse cutting needles in case of delicate tissues like bowel and blood vessels. Okay, so that is how you choose your needles. And then size of the suture material. Okay, so there is a lot of elaborate discussion on the nomenclature of the size. So remember this, 0 or 10 is a size of the suture material. So 20, 30, 40 and 50 are successively smaller sizes. Okay, greater the number before the dash and 0, smaller the suture material. Whereas we have another type of size, naming, that is number 1, number 2, number 3. When you're not using dash 0, when you're saying number 1, number 2, number 3, greater the number, greater the size of the suture. Okay, or the greater the cross section of the suture. If you want a detailed, breakdown of the gauge of the suture material, the metric gauge and the US gauge, you are free to refer the section on basic principles in Bailey and Love, textbook, short practice of surgery 27th edition. You have a very detailed breakdown of the suture sizes. Okay, let's not spend more time on this. Let us move on to other things like Foley's catheter. Okay, this is a very, very versatile instrument or object that is used in our surgical ward. And this is one thing that most new interns fail to use properly and, cause a lot of issues, which is why you should know about the Foley's catheter properly. So the Foley's catheter is made of either latex or silicone. Both varieties are available. The latex Foley's catheter is yellow in color. The silicone one is transparent. Okay. So what is the speciality of the Foley's catheter? It is a self-retaining catheter. That is, it has a self-retaining mechanism at the tip. That is, it has a balloon which can be inflated. So once the balloon is inflated, it snugly sits at the neck of the bladder and it cannot be pulled out, right? So it will prevent you from pulling out the catheter once the balloon is inflated. And then it has a blunt tip. The tip is blunt and rounded and it is closed. And a little, proximal to the tip, you have a hole. So that hole is the channel for the urine to enter the catheter. So that is how the urine enters the catheter. Okay. And then down there, you can see different channels. You can either have a 2-channel Foley's catheter or 3-way Foley's catheter. So the 2-channel Foley's catheter has 2 channels, obviously. One is for draining the urine and the other one is for inflating the balloon. So on this channel where you inflate the balloon, you will have different colors. So the colors will signify the size of the Foley's catheter. For example, 16 French Foley's catheter is orange and 18 French is red in color. Okay, you can refer to the different sizes there. And then also written on the port where you inflate will be the maximum volume of volume that can be pushed to inflate the balloon. Okay, so that is usually specified there. So you should not inflate more than that. And one very, very, very important thing that you have to keep in mind is, what do you inflate the balloon with? Anybody? What do you use for inflating the balloon?
Sterile water.
Sterile water. Can you use normal saline?
No, ma'am.
Very good. You're all very, very bright final year. So when you become interns, your PGs can be very peaceful, because what happens if you inject normal saline? It will crystallize.
Crusting will, yes.
Yeah, it will crystallize and it will block the balloon. You cannot deflate it later when you're removing the catheter. Okay. So never, never, never inflate the balloon of a Foley's catheter with saline. We all remember this. If this is the one single take-home message of this entire class, I will be very happy. Okay. Very good. Then, so one other thing that they will ask you, if you have identified the Foley's catheter properly during your VIVA VOCE, is what is the length of the male urethra? Does anyone know?
25 centimeter.
Who said that? Okay, you are overestimating the length of the male urethra. Let us see if anyone else tells the proper number.
18 to 20 centimeters.
Okay, very good. 18 to or 16 to 20 centimeter. Okay, so that is generally the length of the male urethra. So one thing that you have to, why is this important? Especially for an intern who is asked by their PG to catheterize a male bladder. It is very important because you have to push the Foley's catheter all the way up to the hilt to be on the safer side, or at least for a length of 18 to 20 centimeter before you inflate the balloon. What will happen if you inflate the balloon when, if you don't insert it all the way and you inflate the balloon, what will happen?
Urethra rupture.
Very good. You will end up rupturing the urethra. So if while you are inserting the Foley's catheter, if there is no free flow of urine, or if you have not been able to freely advance the Foley's catheter all the way up to the hilt, please do not inflate the balloon, because if you inflate the balloon, you will invariably inflate it when it is within the urethra, and it will give the patient a stricture. Say the patient came with something else like a pelvic fracture. You don't want to send him home with a stricture, right? So even if you can't help the patient, do not harm the patient. So do not inflate the balloon when it is within the urethra. Okay. So then they will ask you the steps of catheterization. First, you always remember that a catheterization or any other sort of invasive instrumentation has to be performed with all sterile aseptic precautions. So you first take consent of the patient, you expose the patient properly with adequate privacy, and then you paint the area, you drape the area, and then you, if you are performing the catheterization of a male patient, you will first, after painting, you use 3 swabs. You first clean the perineum, then you clean the foreskin, then you retract the foreskin, and then you clean the glands with the sterile solution. And then once you have done that, you take a 10 ml syringe and fill it with 2% lignocaine jelly, and then you inject the jelly into the urethra. So once you've done that, you wait for a little while for the local anesthetic to act, and then you advance the you open the Foley's catheter from its sterile packaging carefully, using all aseptic precautions, and then you advance the catheter all the way up to the hilt. Then once you confirm the free flow of urine, then you inflate the balloon, and then you connect it to a urosac bag. Okay, so that is how you catheterize a male patient. What is the length of a female urethra? Anyone in the audience?
4 centimeters.
4 centimeters.
4 centimeters. See, okay. So here you don't have to push it all the way, but you give some margin and push it a little beyond 4 centimeters before you inflate the balloon. Okay. So you pretty much follow the same procedure, except that you do not have to push 10 ml of jelly. It is enough if you lubricate the tip of the catheter while you lubricate the entrance of the urethra, the urethral meatus, and the tip of the catheter before you advance it. Okay. Then we have the red rubber catheter. This is done to temporarily drain the urine. Okay. So how do you recognize it? It has a blind ending blunt tip with an eye a little proximal to the tip. Okay. So how do you sterilize a red rubber catheter?
Ethylene trioxide. Ethylene trioxide, ma'am.
Okay, that is one way of ETO is one way of doing it. You can even autoclave it at a lower temperature for a lesser time. Okay, red rubber catheters can be autoclaved. Okay, then you have something known as a Malakoff's catheter. So Malakoff's catheter is it appears quite similar to a Foley's, but it is never inserted perurethally. Okay, it has a kind of flowery tip. Just away from the tip, it has a flowery kind of configuration. So that is the self-retaining mechanism of the Malakoff's catheter. So it is generally used for suprapubic cystostomy. Okay. So once you perform a suprapubic cystostomy, in order to drain the bladder, you can place a Malakoff's catheter. It can also be placed inside abscess cavities to continually drain the abscess, especially if there is a residual abscess. So always remember, you never place the Malakoff's catheter perurethally. It can also be used instead of an abdominal drain. Okay. Then you have another examiner's favorite, that is the Ryle's tube. Okay. So what is the Ryle's tube? It is a very, very versatile tool that can be used for a lot of applications. It can be used for nasogastric aspiration. It can be used for nasogastric feeds. It can be used as a feeding tube for jejunostomy as well. It has a lot of very, very versatile indications, okay, and uses. So how do you identify a Ryle's tube? So it is a transparent tube with a blind end with a radio opaque short at the tip. Okay, and the tip is blind ending and blunt, and away from the tip you have an eye, and you have multiple lateral serrations at the distal end of the tube, and then you have 3 different markings along the length of the tube. You have a single line, a double line, and a triple line. So one very, very common question that they ask you is, what is the distance of the what do these distances correspond to? Okay, the first mark is something that is seen 40 centimeters from the tip of the Ryle's tube, and once you insert the Ryle's tube, if the first mark is at the nostril, it means that the tip of the Ryle's tube is at the cardia of the stomach or at the esophagogastric junction. Okay. So another question for you. What is the distance of the esophagogastric junction or the GE junction from the upper central incisor?
45 centimeters.
Huh? Somebody answered. I want the same answer louder.
45 centimeters.
Very good. It is 45 centimeters. So when you are doing an upper GI endoscopy at the 45 centimeter mark, it means that you are at the esophagogastric junction. What is the length of the esophagus?
25 centimeters.
Very good. Very good. And so that is how you can remember that around 40 centimeters, if the tip, if the first mark is at the nostril, it means the first mark is 40 centimeters from the tip, right? It means that you are in the cardia of the stomach. Then the second mark is at around 50 centimeters from the tip. And if the second mark is seen at the nostril, it means that you are in the body of the stomach. And then the third mark is around 55 centimeters from the tip. And if the third mark is at the nostril, it means you are in the pylorus of the stomach. And that is why whenever you want, gastric aspiration or you want gastric feeds through the Ryle's tube, you place the Ryle's tube such that the nostril is at a point between the second and the third mark. Okay, that is when the tip of the Ryle's tube is within the gastric cavity. And the fourth mark corresponds to 65 centimeters from the tip, and that means that the Ryle's tube has been If it is appearing at the nostril, it means that the Rayleigh tube is passed all the way up to the duodenum. Okay, so the length of the Rayleigh tube will vary. It varies between 105 to 120 centimeter, and then there are different gauges of the Rayleigh tube, different calibers of the Rayleigh tube. What you see here is a 14 gauge Rayleigh tube, that is the green color. The 16 gauge is orange and the 18 gauge is red. Okay, so we use larger tubes for feeding generally. Okay, and the Rayleigh tube, again, it has so many questions that accompany it if you identify it properly. They will also ask you what is the best position to insert the Rayleigh tube. Anybody? Anybody in the audience?
Position.
Yeah,
Sitting position, forward
Fowler's
bending.
position is considered the best position to insert the Rayleigh tube. Very good. Okay, so then they will also ask you about the indications for Rayleigh tube feeds. They will ask you for indications of nasogastric aspiration. So you should be well versed with all this. Then we have the flatus tube. So this is a reusable rubber tube that is used for removing the flatus in patients with, bloating. You can also use this for treating sigmoid volvulus. So if you insert the flatus tube, sometimes if it is a very, recent onset volvulus, it can derotate spontaneously after placing the flatus tube. It can also sometimes be used to reduce an intussusception, and it can also be used for introducing a barium enema. Okay, very straightforward instrument. Then we have another very important instrument known as the Kerr's key tube. Okay, so this is a transparent tube in the configuration of a T. It has a horizontal limb and a vertical limb of a variable length. So the Kerr's key tube is generally used after you perform a choledochotomy. Do you remember when we were discussing the Desjardins forceps, we were talking about choledochotomy. So once you've done choledochotomy, you insert the T tube. So the horizontal limb goes into the proximal and distal aspects of the common bile duct, and through a small, choledochotomy, the vertical limb will exit, and the vertical limb is brought out through the abdominal wall, and it is connected to a drain. Okay, so generally after a choledochotomy, the Kerr's key tube is placed in situ for about 14 days and then removed. Okay, it can be used to perform a T-tube cholangiogram, which is one other thing that can be asked during your exams. One other important instrument is proctoscope. Okay, this is used for, it's actually more correctly and more technically an anoscope. It is used for performing a parectal examination in the examination of fistula or hemorrhoids. Okay, so the proctoscope has two parts. The outer part is called a sheath and the inner part is called an obturator. Okay, so then if you identify the proctoscope properly, they will ask you what is the position of the patient for performing a proctoscopy. Anyone in the audience?
Sims position.
Yeah, Sims position. What is Sims position?
Left lateral position.
Yeah, left lateral position with
flexed hip and knee.
Yeah, which hip and which knee?
Right.
Very good. So that is the position, that is the classical position for performing a proctoscopy. Alternatively, you can put the patient on left lateral decubitus with both flexed knees, or you can put the patient on all fours and perform a proctoscopy, or you can put the patient in a lithotomy position. That is generally done in most bottom surgeries. Okay, but the most common office position for performing a proctoscopy is a Sims position. Very good. Okay, so this was a very, very brief overview of the commonly used instruments. There can be many more instruments, but I just made a list of the frequently quizzed instruments and put it on the slides here. If there are any doubts, you can ask me about it later. We are actually running out of time, so let us quickly move through the radiographs, commonly used, commonly quizzed radiographs in surgery. So what is your basic approach? You should identify the film, whether it is a plain radiograph or a contrast radiograph, and what is the anatomical site that is being, depicted. Is it a chest X-ray or an abdominal X-ray or an X-ray KUB or a pelvis X-ray? And what is the view? Is it an AP view or a PA view or a lateral view or an oblique view? So these things are of paramount importance when you begin reporting your X-ray. You do not straight away give the diagnosis. You first say, this is a plain radiograph or a contrast radiograph of the chest in a AP view or a anterior-posterior view or a posterior-anterior view or a lateral view or an oblique view. So you first say that, and if it is a contrast radiograph, you say whether it is a barium swallow or a barium kneel or a barium follow-through or a barium minima, whether it is a single contrast study or a double contrast study. So all these things have to be commented upon before you actually move on to the specific details. So let us quickly go through a few commonly seen radiographs. I am sorry, the slides will also display the diagnosis here. But let me ask you, why do you say that this is a pneumothorax? Anybody in the audience? And which side is the pneumothorax on?
Left side.
Left side. Very good. So why do you say that this patient has a left pneumothorax?
Ma'am, because there is hyperlucency, increased black shadow in the left lung field. Ma'am.
Yeah, that is very important. So there is hyperlucency of the left lung fields. What else do you see? In the hyperlucent area, do you see any bronchovascular markings?
No, ma'am.
That is one very other important thing that you have to keep in mind. In a pneumothorax, the hyperlucent field will not show any bronchovascular markings because there is no lung tissue there. What else do you see in this radiograph in addition to a hyperlucent left field? Can you see something near the hilum or the supposed hilum?
Yes, ma'am.
Yeah. So can you see something along the left cardiac border? Is the left cardiac border entirely normal? So what is that thing that you see, that grayish thing?
Collapsed lung.
Very good. That is the collapsed lung. So what has happened here is there is accumulation of air in the pleural cavity, because of which the lung has collapsed to this size. Okay. So the goal of any treatment is to make the lung re-expand. So what is the treatment for a pneumothorax? For a non-tension pneumothorax, how do you treat it? Anybody?
Intercostal drainage.
Yeah, intercostal drainage, intercostal tube drainage. So you insert an intercostal drain. So if you answer this question correctly, you will be asked about the technique of introducing an intercostal drain. And they will ask you what is the triangle of safety. Okay, you quickly revise through the triangle of safety. And then they will ask you about the concept of underwater seal. So when you insert a chest drain, it has to be compulsorily connected to an underwater seal. So otherwise it will permit re-entry of air and it can complicate the situation even more. So you should understand the technique of inserting an ICD, the boundaries of the triangle of safety, and you should also understand the mechanism of an underwater seal. Because there is very little time, I will not explain that in detail. If there are any doubts, you can always contact me. So this is another X-ray. Why do you call this a hemopneumothorax? Which side is the hemopneumothorax on? Anybody in the audience?
Left side, ma'am. Straight line border.
Yeah, so there is a straight line border. And why am I saying this is a hemopneumothorax? Why is it not a hydropneumothorax? Can you tell? Are you looking at the X-ray? The answer is no, you cannot tell. It can be a hydropneumothorax or a hemopneumothorax, but in the setting of trauma, an acute presentation like this should make you think of a hemopneumothorax, especially if there is a concomitant rib fracture. Okay, so what you see is a straight level, okay, straight fluid level with hyperlucency above it. Now that is characteristic of a hemopneumothorax. So again, the treatment is intercostal drainage. So what are the indications for a thoracotomy in hemopneumothorax? So what should be the volume of blood that comes out over 24 hours or at once? All those cutoffs you should know. Okay. Then we have cannonball secondaries. What are cannonball secondaries? They are
Metastasis to lung.
Yeah, hematogenous spread to the lung. Okay. So why do they assume a circular shape or a spherical shape? Why can't they be in any other shape? Why can't they be triangular or square or irregular? Why are they rounded? Okay, the answer is due to surface tension. So which is the shape with least surface tension? Okay, you've all forgotten your physics. Go read it up.
Spherical. Spherical.
Okay, very good. Okay, so here we have, what do you have? What do you seen the
Air under
diagram?
diaphragm.
Yeah,
Air under diaphragm.
which okay. So what is that sign called?
Leaping
That
dolphin sign.
semilunar air shadow under the hemidiaphragm. What do you call it?
Cupola sign.
Very good. It is called cupola sign. Okay. So if you identify this properly, okay, air under the diaphragm, or free air under the diaphragm, or pathological free air under the diaphragm, or pneumoperitoneum is detected best on which film? Is it on an abdominal X-ray or a chest X-ray?
Erect chest X-ray.
Very good. It is best detected on an erect chest X-ray. Okay. And what is the minimum amount of free air that can be detected radiographically?
10 mm.
Actually, even volumes as low as 1 to 5 ml can be detected on a X-ray, on a radiograph. Okay. And it is best detected on an erect chest X-ray rather than an abdominal X-ray. Okay. And then what are the other important signs of pneumoperitoneum that you know? One is cupola sign, which you can see here. Okay. There are several other signs. One other sign you can actually see in this image, especially on the one on the right hand side, towards the left upper quadrant of the abdomen. What sign is that? You can see both the outlines of the wall of the bowel, right? What sign is that? Okay. So it is called Wriggler sign, R-I-G-L-E-R, Wriggler sign. Okay. That is when you can see air on both sides of the bowel wall. Okay. It is also called double wall sign or bas relief sign. Okay. Then there are so many other signs of pneumoperitoneum. It is a hot favorite. They will ask you what is football sign, what is inverted V sign, what is Doge cap sign, what is falciform ligament sign, and then a telltale triangle sign. So all these are different signs of pneumoperitoneum. And then there is something called pseudo-pneumoperitoneum or Chilaiditi syndrome. Does anyone know what that is?
Ma'am, interposition of transverse colon between the liver and
Right
diaphragm.
hemidiaphragm. Very, very good. You guys are really bright, man. Really. Very, very nice to know that. Okay. So let's move on to the next radiograph. What do you see here quickly? Don't need to diagnose.
Levels are seen. Multiple air fluid levels are seen.
Yes. And what is the configuration of the multiple air fluid levels? Is it central, peripheral? It is towards the center, right? It is centrally placed, multiple air fluid level with what? Can you see something very, very prominent in the dilated bowel loops? What can you see?
Valvulae conventus.
Very good. What are valvulae conventus? Who answered? What's your name?
Rishabh.
Rishabh. Very good. So what are valvulae conventus?
The mucosal folds.
Very good. They are circumferential, complete mucosal folds, which are characteristic of which part of the small bowel?
Jejunum.
Which part of the small bowel do you see valvulae conventus?
Jejunum.
Come on. Jejunum. Very good. And what is the characteristic of ileum?
Featureless loop of
Yeah, it is characterless. The ileum is featureless or characterless. Okay. So this means small bowel obstruction mainly involving the jejunal loops with multiple air fluid levels. Okay. Okay. Let us move on to the next radiograph. What do you see here?
Again, multiple air fluid levels more at the
Howda.
periphery.
Can you see fluid anywhere? I don't see any fluid. You can see dilated bowel. Can you see fluid levels here?
Air shadows can be seen.
Yeah, multiple air shadows. I mean, multiple intraluminal air shadows involving the periphery. So signifying dilatation of the large bowel. Okay. So what do you call the septations here? You call them hostrae. They are not circumferential. They are incomplete projections into the lumen. Okay. So they are hostrations. So this is a X-ray showing large bowel obstruction. You also will need to know the cutoffs of the maximum diameters of the different parts of the bowel. Okay. What is the cutoff for the, to call it significant bowel dilatation? What is the cutoff for large bowel?
6.
Oh, okay. there is something called 369 rule. Okay. For small bowel, if the caliber of the lumen is more than 3 centimeter, it is significant. For the large bowel, if it is more than 6 centimeter, it is significant, except for which is the most distensible part of the large bowel?
Cecum.
Very good. So the cutoff there is 9 centimeter. Okay. So this is something that they will ask you. So what do you see here? What is this sign?
Coffee bean sign.
Coffee bean sign. Very good. It is characteristic of sigmoid volvulus. Okay. So the hilum of the coffee bean is directed towards the left lower quadrant. So that is generally what is seen in the sigmoid volvulus. Okay. And then what is the treatment for sigmoid volvulus? How do you treat sigmoid volvulus?
Derotation.
Compression.
Yeah, you do derotation and then you simply derotate. Once you derotate it, you will simply put it back in the abdomen and come out.
We
Do you
will
do
check
anything
for
else?
bowel whether it is viable or not viable.
Yeah, you will check for viable. If the bowel is viable, what do you do? If the bowel is not viable, you will do resection. If the bowel is viable, what do you do?
Hartmann's procedure.
What do you do?
Hartmann's.
Hartmann's procedure is not done when the bowel is viable. If the bowel is not viable, then because it can, if Hartmann's is not done. Hartmann's is more like a bailout procedure when you do not want to dissect lower into the pelvis. Okay. You can either do a resection with a primary anastomosis and bring out a proximal covering stoma, or you can bring out both ends of the bowel out as a double barrel stoma, or you can simply do a primary anastomosis. And in previous times, they used to say if the bowel was viable, you simply derotate it and fix it to the abdominal wall or the pelvis. That is called a sigmoidopexy. But today the standard of care is to perform a sigmoidectomy. You resect the sigmoid colon even if the bowel is viable, because what is the pathogenesis of sigmoid volvulus? There is a long redundant length of sigmoid colon which will cause the colon to twist over itself and form the volvulus. So the recommendations currently are to perform a sigmoidectomy and perform an end-to-end anastomosis. Okay. Then what do you see here quickly? What is this? It is an X-ray. What is the part?
Kidney.
Yeah,
KUB,
it is a plain X-ray KUB. Okay. It is showing, what is it showing bilaterally?
Opacification.
Yeah, it is showing it's showing staghorn calculi, irregular opacification, and you can even see the faint renal outline, especially on the right side, right? So this is a staghorn calculus. So again, they will ask you different types of renal calculi based on the composition, and how do you treat, when do you do a pylolithotomy, when do you do a PCNL, when do you do a URSL. There are so many things that they can ask you. And then they will ask you about different types of urological imaging, such as an intravenous pyelogram. Then they can ask you about retrograde ureterogram and micturating cystourethrogram. I have not covered all of this because we barely have any time. Okay. Then we have vesical calculus here. How do you know this is a vesical calculus? What can you see?
Radio opaque.
Yeah, it is radio opaque, and then the shape. Okay, it is assuming the contours of the bladder. And if you can see clearly, there are multiple concentric lamellations. Okay, so they are characteristic of a vesical calculus. So again, they will ask you about the different methods of treating a vesical calculus. You can do a cystolithotomy. What are the other methods of treating vesical calculus? What are the minimally invasive methods? Anybody?
Shockwave lithotripsy.
Very good. Shockwave lithotripsy. Okay, not for you don't utilize shock waves for bladder calculi. You can probably use it for ureteric calculi. But how do you treat bladder calculi?
Transurethral cystolithotomy.
Okay. Yeah. So then there is another method known as cystolithotripsy. Okay. And then cystolitholapaxy. Okay. Read up on all these. Okay. There are different procedures. So a few contrast images. What is this? What kind of contrast image is this?
Barium.
It is a barium.
Swallow.
Very good. It is a barium swallow showing the
Dilated
esophagus, right?
esophagus and terminal.
Yeah,
peak
there is
appears.
terminal tapering, okay, and a cut off, okay. So this is seen in achalasia cardia. So they will ask you, how do you differentiate between achalasia cardia and CA esophagus? What do you see here? There's an abrupt cut off and an irregular filling defect in the esophagus, okay. So that is how you differentiate. Again, you have to go through achalasia cardia. So this is bird beak sign, pencil tip sign, rat tail appearance, all of that you will be quizzed upon, okay. Then they'll ask you what is sigmoid esophagus, all of those things. We're running very short of time. Okay, so this is a gastric ulcer. So you see what is known as a niche and notch pattern. So the niche is actually formed by the ulcer. So the ulcer is actually on the lesser curvature. So the ulcer seems like a protuberance on a contrast study, right? Because the contrast goes inside the ulcer. So that is seen as a protuberance or the niche. The notch is formed by the, circular contracting due to the cicatricial process of the ulcer. So this niche and notch pattern is something that you see in gastric ulcers. Then they'll ask you the differences between a benign and a malignant ulcer, which you will have to read up, okay. Then this is diverticulosis. What is this sign called? It looks like a sawtooth, right? It looks like sawtooth appearance. So this is something that is seen in diverticulosis. Again, you have to read up about the different sites of diverticulosis, which part of the colon does not show any diverticula, all those things. So what is this sign called?
Apple.
Quickly, we are running out of time. We are already shooting past our cutoff.
Apple core sign.
Very good. It's called an apple core sign. Very good. So you have to know about the different types of growths in the left side of the colon, on the right side of the colon. How do they present? All those things. Okay. Then this is something known as a double contrast enema. So what are the two contrasts used here? One is barium, the other is air. Okay, so in a double contrast study, one contrast material is barium, the other is air. So what happens is you first give barium, a thin coat of barium is allowed to coat the mucosa, then you insufflate air, okay. That will spread the contrast material over the mucosa, and then when you inject it again, you can see the mucosal irregularities in sharp contrast. So what do you see here? What is the pathology here? So it is diverticulosis. All those small outpoachings that you see are diverticula. Okay. And then specimens, very, very quickly. We don't have any time, I'm sorry. So the basic approach is you first identify the organ, and if possible, you also identify the surgery, and only then you comment on the pathology. Okay, so here you have a thyroidectomy specimen. The first one shows normal thyroid tissue and the brownish substances. Inside is the colloid, okay. And that brown part is the colloid, and that irregular thing that you see there is a tumor, or it is a growth. It's an adenomatous growth. And then there are also some papillary projections that you see. So the diagnosis is papillary carcinoma thyroid. Sometimes you can even see macroscopic calcifications in the papillary projections. So that is one common specimen. Here you see the specimen of a mastectomy. Okay. So they will ask you, how do you identify it? You can obviously see a spindle of skin with the nipple areola complex. So they will ask you the different types of mastectomy and the structures removed. What is radical mastectomy? What is modified radical mastectomy? What are the three named types of modified radical mastectomy? Okay. And then how do you mark a mastectomy specimen? You tag the superior edge and the lateral edge. Okay. You put a short suture tag on the superior edge and a long suture tag on the lateral edge. Okay. That is how you identify. And then they will ask you about the steps of mastectomy, about the different groups of levels of lymph nodes, and what are the limits of dissection. Okay. You should be thorough with all this. So specimen identification is one part, and actually answering the questions on the pathology and the surgery is another part. So here you see the gallbladder, okay, with stones. So what is the type of stones that you see here quickly?
Mixed.
Yeah, and they are faceted stones, right? You can see facets on the stones. So whenever you see a large single faceted stone, it means you have to look for another stone, because the presence of facets means that multiple stones have been rubbing against each other. Okay, so there can never be a single faceted stone. Always remember that. And what do you see here? A cut section of the testis showing It is a uniform, tan, homogeneous, fleshy growth. What is that?
Seminoma.
Seminoma. So it is seminomatous testicular tumor. So if it is heterogeneous with areas of necrosis and hemorrhage, it is
Non-seminomatous.
very good. Then, okay, what is this? This is specimen showing CA penis. So what is the histopathological type of carcinoma?
Squamous cell.
Yeah, squamous cell carcinoma. Okay. And then they will ask you about the pre-malignant conditions of the testis. They can ask you about the pre-malignant conditions involving the glands. What is the pre-malignant condition involving the glands of the penis?
Balanitis.
No. Okay. Yeah, that is okay. That is a pre-malignant condition. But what is a pre-malignant? What is another pre-malignant condition involving the glands of the testis? Erythroplasia of Querate.
Querate.
Okay, very good. Well, then what is Bowen's disease? It is a pre-malignant condition involving the shaft. Oh, okay. You should go through all the pre-malignant conditions of the penis. Okay, and then you should know about partial and total penectomy. And what do you do when you do a total penectomy? What do you do for the patient's urination? How do you arrange for it?
Perineal urethrotomy.
Very good. You do a perineal urethrostomy. Very, very good. Now, okay, final specimen. So this is a specimen of CA rectum. So when you do surgery for CA rectum, be it abdominal perineal resection or a low anterior resection, what is one very, very essential component of CA rectum surgery? So it is TME, okay, total mesorectal excision. Okay. So this is something that you should know. So you should know about the recommended proximal and distal margins. What is the recommended proximal margin in colorectal malignancy? It is 5 centimeters. Okay. And the distal margin is supposed to be at least 2 centimeters. Okay. And then you should know about the different, measurements. What is the distance of the dentate line from the anal verge? What is the length of the rectum? What is the length of the renal canal? Then how do you classify rectal growths? And how do you preserve the sphincter? Then, yeah, what is the anatomy of the diaphragm, the pelvic diaphragm, the levator muscles? All of those things you should know. Okay. And then you should know in detail about colorectal malignancies. So they can even keep hemicolectomy specimens. They can keep, LAR specimens or APR specimens, depending on what you get. Then they can also keep other specimens like, splenectomy specimens. They can keep gastrectomy specimens with growths and the kind of growth, whether it is an ulcerative growth, ulceroproliferative growth. So a very good idea before you attend your VIVA VOCE session is to know what is actually kept in your own institution. Okay. So your own institution will have its own set of unique instruments, their own set of surgical specimens that can be displayed. So if they call for a class in which they revise all this, it is a very, very good idea to attend the class. Okay. So all the best, stay very confident, brush up everything thoroughly and do very well. If there are any doubts, you can ask me either now very, very quickly, or you can always write to me or email me. Okay. I hope you all benefited from this class. I again thank White Army for this opportunity. Thank you.
Thank you, ma'am. It was a very detailed, informative session. This would help all the final year students during their practical examination a lot.
Thank you so much.
Thank you so much, ma'am, for taking your time and taking this
thank
class
you as
for
well.
everyone. Yes. If there are any doubts, please put it in the chat box.
Okay.
Ma'am, if there are no doubts, shall we wind up the session?
Yeah, let's wind up.
Okay.
Very
Thank
nice.
you so much, ma'am, for this.
Okay, thank you so much.